Welcome back, everyone. I'm so glad you could join us today because we're talking about one of the most talked about topics in healthcare right now, which are GLP-1 medications. You've probably heard the brand names of Ozempic and Wegovy and Mounjaro, or the generic names of tirzepatide or semaglutide. I mean, they're everywhere. They're in the news, they're in the social media, they're in the doctor's office. And honestly, with all the noise out there, it's hard to know what is real. So today, we're going to cut through the hype. We're going to talk about what these drugs actually are, how they work inside your body, and what the science says about the risks, including the ones that barely anybody talks about. Most importantly, we're going to talk about how to use these medications strategically as a tool rather than a magic fix, because the research is very clear. The only tool that works long-term is if you build the right habits alongside it. So let's start at the beginning. GLP-1 stands for glucagon-like peptide 1. It's not a drug. It's actually a peptide that functions as a hormone inside your body naturally. When you eat, your gut releases GLP-1 as part of the signaling cascade that tells your brain, hey, we've got enough food, slow down. It stimulates insulin release and suppresses glucagon, which is the hormone that raises blood sugar. It also slows gastric emptying, meaning food moves slower through your stomach and keeping you fuller longer. The problem in people with obesity and type 2 diabetes is that the system often doesn't work as well as it should. The GLP-1 signal is blunted. So pharmaceutical researchers said, hey, what if we create a molecule that mimics that signal but lasts much longer than the natural hormone? That's exactly what GLP-1 receptor agonists do. The natural GLP-1 hormone breaks down in your bloodstream within minutes. These medications are engineered to last days, or in the case of the once-weekly injections, a full 7 days. The most well-known right now are semaglutide, which is sold as Ozempic for diabetes, and Wegovy for weight loss, or tirzepatide, which is sold as Mounjaro for diabetes, or Zepbound for weight loss. Tirzepatide is actually a dual agonist, meaning it activates two hormone receptors, the GLP-1 and another hormone called GIP, or glucose-dependent insulinotropic polypeptide. Dual action is why tirzepatide tends to produce even greater weight loss than semaglutide alone. A 2024 review in Frontiers of Endocrinology described tirzepatide's mechanism of action as potent and imbalanced coagonism at both the GIPR and the GLP-1R, producing significantly higher insulin response than either hormone alone. Now, how do these drugs drive weight loss? It's not just appetite suppression, it's way more sophisticated than that. A 2025 review in the American Journal of Medicine outlined both central and peripheral pathways. Centrally, GLP-1 receptors exist in the areas of the brain involved in the reward and appetite, including the hypothalamus and the brainstem. These drugs essentially reduce what researchers call the hedonic drive to eat, the urge to eat for pleasure rather than hunger. Peripherally, they slow stomach emptying, enhance insulin sensitivity, and reduce systemic inflammation. Clinical trials have been remarkable. The STEP 1 trial showed that participants using semaglutide 2.4 milligrams weekly lost an average of nearly 15% of their body weight over 68 weeks. Tirzepatide in the SURMOUNT trials showed weight loss up to 22% of the body weight at the highest dose. These are numbers we haven't seen from non-surgical intervention before. So yes, these are generally powerful tools, but power cuts both ways, and that brings us to muscle. Unfortunately, this is not something that is talked about nearly enough when people celebrate these drugs. If you are just losing fat on a GLP-1 medication, you are also losing muscle too. Now let me give you the numbers. A 2024 systematic review and network meta-analysis published in Metabolism, Clinical and Experimental, found that lean body mass, that is everything that isn't fat, muscle, bone, organs, can account for 20 to 40% of total weight loss on GLP-1 receptor agonists. That means if someone loses 50 pounds, they may be losing 12 to 20 pounds of that from muscle. That's not a minor side effect. That's a major physiological consequence. The Semaglutide study, published in 2024, followed 115 patients with obesity over a 24-month period on semaglutide. They found that at 7 months, lean mass had declined by 3 kilograms, or about 6.6 pounds, alongside fat loss. The lean mass stabilized somewhat by month 12, but the reduction was real and measurable. Why does this happen? Partially, it's physics. When you eat far less, your body doesn't discriminate perfectly between fat and lean muscle. It draws energy from both. And partly it's because most people on these medications aren't eating enough protein and aren't doing enough resistance training to send the body a signal to preserve muscle. GLP-1 induced weight loss, if not managed intentionally with lifestyle strategy, can move people in that direction. The American Diabetes Association put out a press release in 2024 highlighting that newer GLP-1 therapies are showing some improvement in the ratio of fat loss to lean mass loss. But the problem hasn't been eliminated. The quality of weight loss, not just the quantity, must be the goal. So what do we do about it? We'll get into that, but short answer is protein and progressive resistance training. Those two things are not optional add-ons when you're on a GLP-1 medication. They are essential. Now here is why muscle loss matters beyond just aesthetics. Muscle is your primary metabolic engine. It is the primary site of glucose disposal in your body. More muscle means better insulin sensitivity, a higher resting metabolic rate, and more functional capacity as you age. Losing significant muscle mass during a weight loss intervention sets you up for problems down the road, problems that are directly relevant to what we're going to talk about next. What happens when you stop the medication? Now let's talk about when you stop a GLP-1. Let me tell you about one of the most important studies that almost nobody talks about when they're promoting these medications, the STEP 1 extension trial. The STEP 1 trial showed that semaglutide produced remarkable weight loss over 68 weeks, but the extension researchers followed participants for 1 year after they stopped the medication, with lifestyle counseling continuing throughout. What they found was sobering. Within 1 year of stopping semaglutide, participants had regained 2/3 of the weight they had lost. That's 2/3. Published in the Diabetes, Obesity, and Metabolism in 2022, the paper by Wilding and colleagues was essentially a warning. The drug works while you're on it, but when you stop, the biology that drove your obesity in the first place reasserts itself. And it's not just willpower. This is biology. When you stop the GLP-1 medication, the appetite-suppressing signals go away. Ghrelin, the hunger hormone, surges back up, and leptin, the hormone that signals fullness and satiety, drops. Your body actually reduces its metabolic rate as a compensation for having been in a caloric deficit. It does everything it can to restore the lost weight because, by evolutionary standards, fat stores equal survival. A 2026 systematic review and meta-regression published in The Lancet modeled the trajectory of weight regain across multiple trials. They estimated that the maximum weight regain of 75.3% of lost weight within a half-life of about 23 weeks, meaning that within about 6 months of stopping, people were more than halfway back to where they started. What's more alarming is what they gain back is the fat. They haven't gained the muscle that they lost. Caloric requirements on a daily basis are much lower than when they started in the first place. Now, does this mean these medications are useless unless you take them forever? Not necessarily, but it does mean something critical. The medication is not the solution by itself. It's a window. It's a physiological window to reduce appetite that gives you the opportunity to build the habits that can outlast the drug. The 2024 article in MedCentral reviewing this data framed it well. Clinical guidelines on how to stop GLP-1 medications without rebound are essentially still lacking. There's a real gap in the research here. But what we do know is that the people who are most likely to maintain their weight loss are those who use the medication window to build lasting behavioral and physiological changes. And that's exactly what we're going to discuss. I've given you the full picture, the power of these medications, the real risk of muscle loss, and the sobering data on weight regain. Now let's talk about what actually works. What does the science say about combining GLP-1 therapy with lifestyle interventions to get the lasting results? The answer is not complicated, but it does require commitment. And it comes down to 4 pillars: resistance training, protein intake, smart carbohydrate selection, and lifestyle modification. So let's start with resistance training. A 2024 paper in Diabetes, Obesity, and Metabolism by Dash and colleagues titled Opportunities to Optimize Lifestyle Interventions in Combination with GLP-1 based therapy made a powerful point. Increased protein intake alone is likely insufficient to preserve muscle mass without structured resistance training. The exercise sends a stimulus to the muscle fibers that says, you're needed, don't break down. Without that stimulus, protein alone can only do so much. What does resistance training mean in practice? It means lifting weights, using resistance bands, doing body weight exercises like squats and push-ups, Any kind of movement that places a mechanical load on your muscles 2 to 4 times per week. You don't need to become a competitive power lifter. You need to consistently challenge your muscles through a full range of motion with progressive overload, meaning gradually increase the challenge over time. A 2025 review in Frontiers in Clinical Diabetes and Healthcare described the combination of GLP-1 therapy and exercise as yielding additive benefits, including greater reductions in abdominal obesity, oxidative stress, inflammation, and critically, improved weight loss maintenance after stopping the GLP-1s. In other words, the people who exercised while on these medications had better long-term outcomes even when the drug was gone. Now let's talk about protein. This is non-negotiable. When you're in a caloric deficit and GLP-1 medications create a significant caloric deficit, your protein needs actually go up, not down. The research is clear. A 2025 joint advisory from the American College of Lifestyle Medicine, the American Society of Nutrition, the Obesity Medicine Association, and the Obesity Society published in the Journal of Clinical Nutrition recommended protein intake greater than 1.2 grams per kilogram of body weight per day, distributed evenly across meals for people on GLP-1 medications. Many researchers go further, suggesting 1.6 to 2 grams per kilogram for those doing resistance training, especially in older adults. To make this easier in my clinic, what I suggest to my patients is that they eat 1 gram of protein per pound per day. Why distributed across meals? Because muscle protein synthesis, the process of building and repairing muscle, is optimized when you give your body a meaningful dose of protein every 3 to 5 hours rather than eating very little during the day and loading all your protein at dinner. Here's the practical challenge. GLP-1 medications suppress appetite significantly. So a lot of people aren't eating that much at all, and what they are eating is most likely low in protein. That's a dangerous combination. When you're in a big caloric deficit, your muscle is being threatened. You're not giving your body enough amino acids to protect that tissue. So be intentional. Prioritize protein at every meal. Think eggs, Greek yogurt, cottage cheese, lean meats, fish, legumes, and protein shakes if needed. Make protein your first nutritional priority before you think about anything else. Now let's discuss carbohydrates. Notice I didn't say cut carbs. The research doesn't support wholesale carbohydrate restriction as a requirement for long-term success. What it supports is carbohydrate quality. What does that mean? Not all carbohydrates affect your body in the same way. Carbohydrates are digested quickly. Think white bread, sugary cereals, pastries, sweetened beverages cause rapid spikes in blood sugar, followed by crashes that drive hunger and cravings. Carbohydrates that are digested slowly. Think of legumes, vegetables, whole grains, and fruits with their fiber intact. They produce a gentler rise in blood sugar and keep you fuller longer to support stable energy and insulin sensitivity. The Harvard T.H. Chan School of Public Health Nutrition source is unambiguous. The quality of carbohydrates matters enormously for blood sugar regulation and long-term metabolic health. Choosing high fiber, minimally processed carbohydrates over refined ones is consistently associated with better weight outcomes and reduced chronic disease. This is particularly important when you're on a GLP-1 medication because these drugs already work partially by slowing gastric emptying and modulating blood sugar. Pairing them with smart carbohydrate choices amplifies the benefit. Pairing them with a diet high in refined carbs undermines it. And now for the last pillar, lifestyle modification. Lifestyle modifications are an important part of maintaining healthy weight afterwards. From proper exercise routines to meal portion sizes, as well as timing meals, intermittent fasting, and even sleep routines are important to build while you are on the GLP medication so you can have long-term success. So to summarize, resistance training 2 to 4 times per week, protein at 1 gram per pound of body weight at a minimum, distributed across your meals as carbohydrates chosen from whole fiber-rich sources. These are not complicated recommendations. They are well supported by the literature. They are actionable and they are genuinely change the trajectory both while you're on the medications and long after. One final thought on this. The 2024 paper in Diabetes, Obesity, and Metabolism emphasizes that GLP-1 therapy should be understood as a window of opportunity, not the destination. You may not be on this medication forever, But the habits you build while you are on these medications can last a lifetime. The goal is to use the reduced appetite and the improved metabolic environment and the motivation from the results you are seeing to instill the behaviors that become automatic. That is how this becomes transformative instead of temporary. All right, let's bring it all home. GLP-1 medications are genuinely remarkable. The science behind them is solid, and for many people, they represent a breakthrough in obesity treatment that we haven't seen before. But they are not magic, and they are not a permanent solution on their own. The data is clear. Stop the drug without building the right habits, and the weight comes right back. The answer isn't to dismiss these medications. The answer is to respect them as a tool that they are, and to build something durable around that tool. Resistance training to protect your muscles, adequate protein to fuel it, smarter carbohydrate choices to stabilize your metabolism, and build the right lifestyle habits. Understanding that sustainable health is built over time and not dispensed in a weekly injection. Now, if you are considering GLP-1 therapy or you are already on it, please work with a qualified healthcare provider, your physician, a registered dietitian, and a certified personal trainer. These professionals can help you tailor these principles to your specific situation, your age, your health history, and your goals. Now, if they are just giving you the medication without discussing proper nutrition, exercise, and lifestyle changes, run away. They will actually do more harm than good. In my clinic, patients that are on GLP-1 therapy, we have weekly discussions about lifestyle changes, diet, nutrition, and exercise, as well as I give them a copy of my book, Small Changes for Weight Loss. Thank you for spending time with me today. If this episode was valuable to you, please share it with someone who needs to hear it. And if you have questions, I want to hear them. If you're willing to question what you've been told and follow the evidence where it leads, subscribe to the ICONOCAST community. Until next time, take care of that body. You only get one.